We'll continue on with chapter 14, recording 2. So now we're on to history taking. So what's the point of history taking? Well, you want to try and determine what the problem is or what may be causing the problem. Problem also being chief complaint. Those are kind of used interchangeably there. You want to try and gather a thorough history. You may gather information from the patient, family, friends, bystanders. You may just have to investigate the nature of illness just by inquiring about the chief complaint. Ask about the history of the present illness, and then ask follow-up questions to try and gain some more information. If you have an unconscious patient, look for any clues at the scene that may give you an idea of what's going on. So medication containers, medical devices, do a quick check to see if they have on medical alert jewelry. As we gather more history, we're going to use two main mnemonics. So sample is one and OPQRST are the other. And we already went through what sample and OPQRST are, and we'll continue to go through that in lab. You're going to record any allergies, medical conditions, prescription, over-the-counter medications, and herbals, remember. Some patients take numerous medications. Make sure that you list them in your report with you. You want to also determine if the patient has been compliant with those medications. There's a mnemonic that is tacos. It can be helpful in identifying conditions that may be complicating a patient's chief complaint or affecting medications. So these are things that are additive that may be causing issues. So T is tobacco, A is alcohol, C is caffeine, O is over-the-counter medications, also herbal supplements, and S is sexual and street drugs. Your secondary assessment may occur on scene or en route to the ED. If your patient, again, has any problem with anything that you assess in your primary, so A, B, or C, that should be done en route to the ED. If they're doing pretty good, then you can stay and play on scene. In some cases, you honestly may not have time to conduct a secondary assessment, but we want to try and make it that far if possible. For physical examinations, which you'll complete as part of your secondary, all conscious patients should undergo a limited or detailed physical examination based on their chief complaint. For unconscious patients, you're going to do an entire body, also known as a head to toe exam, to try and figure out what's going on with the patient, why they're unconscious. You want to try and complete that head to toe quickly because we're not going to delay transport for this. As you're going through that secondary exam, you're going to examine the head, scalp, and face for possible trauma. You're going to check the eyes, ears, nose, and mouth. For any orifice that we have in the body, you need to check to see if something's coming out of it. So ears, nose, etc. Look at the neck very closely. Look for evidence of accessory muscle use. Check for jugular venous distension, a tracheostomy or a stoma, tracheal deviation. And to check tracheal deviation, you're going to go right in that suprasternal notch and check right there. If you're checking way high up by the thyroid cartilage, if your patient has tracheal deviation that's that high up, they're dead. So it's going to be much, much lower. You want to look at the chest and abdomen. You want to check for breath sounds, palpate, look for any medication patches, rigidity, distension, look for scars, and then move down. You want to check all 4 quadrants. Check the pelvis, genital area as necessary. Palpate the legs and arms, looking for swelling and abnormalities. And then you want to check distal motion, sensation, and circulation. And then the patient's back will be the last thing. Your treatment is going to depend on what you find here and then based on your local protocols. Then we're going to go ahead and assess vital signs. You want to reassess the pulse for, again, not just rate, but quality and regularity. You want to identify the rate, quality, and regularity of respirations, and then any difficulties that you can see. You want to obtain a blood pressure, and it's customary that we get both a systolic and diastolic. There is an alternative way for taking a blood pressure where you're only going to get the systolic reading. Try to obtain a full set of blood pressure readings. You may want to use an automatic blood pressure cuff for future assessment at regular intervals. You can set it to go off every 5 minutes. You can set it to go off every 15 minutes. If you're not getting a good blood pressure, or you think that it just seems off, seems too low, too high, etc., take a manual blood pressure. Don't just rely on your equipment. Sometimes it does fail. You might need to take a blood glucose level, and then a pulse oximetry reading should be done. Blood glucose, you can take that on pretty much anybody. That's it's not really out of character anymore. For reassessment, you want to perform your assessment, perform after your assessment and treatment have been completed. Reassess should start and continue throughout the entire transport. You're going to repeat the primary assessment, reassess your chief complaint, and if you have determined that this is something you can't deal with out in the field and ALS would be more warranted, you may need to call for ALS backup. At this point, it should have been something that you considered early on in the call, because if you're already at reassessment and you haven't called for ALS, chances are you're not going to rendezvous with them. You're going to make it into the hospital before you actually run into them. You want to repeat your physical exam, try and identify and treat any changes, obtain vital signs every 5 minutes for unstable and every 15 for stable. You want to make sure that you review all of the treatments that have been performed and determine what change that caused in the patient, if any. And then you want to document any changes that have developed as a result of treatments, and if needed, make sure that you adjust your treatments accordingly. So, transport and destination. Most medical emergencies are going to require treatment that's well beyond what we can do in the field. It may require advanced testing that, again, we can't do in the field. So we're going to probably transport the majority of our medical patients for medication. EMTs can use AEDs on a patient that's pulseless and apneic, so that may not warrant transport into the hospital. Kind of our guideline on both of the services that I was on was we don't transport dead people. So oftentimes when somebody was pulseless and apneic, unless we could get a shockable rhythm in the field, we did not transport them in. But that kind of depends on what your protocol is. As an EMT, you can only use the AED mode. You can't use the manual mode. So might be a little bit different for you. Scene time tends to be longer for medical patients than for those trauma patients. We can do a lot of treatment on medical patients out in the field. Trauma patients, pretty much they have to get into the hospital and have definitive treatment, testing, and surgery oftentimes. So you want to gather as much information as possible while you're driving to the ED. You don't want to spend a lot of time getting that on scene. Check the patient's living conditions. Excuse me. Critical patients always need transport, rapid transport. Patients with altered mental statuses, those with airway or breathing difficulties, those with any sign of circulatory compromise, and patients who are very elderly or who are very young that you can't adequately take care of in the field. Type of transport. If a life-threatening condition exists, you can choose to include lights and sirens while you're transporting. You're going to need to decide if the lights and sirens are honestly going to expedite your transport time, or if it's going to put you, your partner, and the patient at undue risk. Sometimes it's honestly not worth the extra or earlier 2-minute arrival time to run lights and sirens and put everybody in the vehicle at risk. So make sure that you follow your services guidelines with that. If the patient's non-critical, you don't need to run lights and sirens. You'll do it non-emergent. Non-emergent is much, much safer. Oftentimes it only affects your arrival time by a few minutes, and so it's really not worth it. Most of the time you will go non-emergent back to the hospital. There's a couple different modes of transport. They ultimately will end up falling into one of two categories, either ground or air. Ground transport units are staffed by EMTs and paramedics. Air transport are usually staffed by critical transport professionals, paramedics, nurses, etc. When you consider ALS for the patient, compare the time that's going to take for your ground ALS unit to respond, excuse me, and your air unit to respond, because after they do checks and everything to actually lift off, you may be able to get a ground ALS unit there and headed back to the hospital before you could get air transport out there. So keep that in mind. Destination selection, pretty much it doesn't really matter with us. We've got two hospitals that have similar capabilities. One is not preferred over the other, so the closest typically wins. There are some situations where you might choose one hospital over the other, but not really something we have to worry about here like they do in larger cities, because they have trauma centers, they have heart centers, they have stroke centers. We don't have that here. Infectious diseases. So kind of general assessment principles for that. You're going to approach like any other patient. You're going to perform a scene size up, take standard precautions, and complete that primary assessment. You're going to gather history using OPQRST so that you can get more information about the patient's chief complaint. Typical complaints that go along with infectious diseases tend to be fever, nausea, rash, pleuritic chest pain, difficulty breathing, vomiting, and diarrhea. You then want to go ahead and ask your sample questions, get a set of baseline vital signs, and pay particular attention to any medications as well as the events leading up to the problem. You want to ask if someone's recently traveled, come in contact with someone that's traveled, have they been around anybody that is exhibiting similar signs. For management principles, you want to focus on any life-threatening conditions that you identify in your primary assessment. Try and be empathetic to the patient. Sometimes this can be pretty scary. Place the patient in a position of comfort on the stretcher, keep them warm, use standard precautions or what's appropriate for that patient. Your agency will always have an exposure control plan for cleaning equipment. Make sure that you properly discard any disposable supplies, wash linens, and if there's something that you need to report as far as you've come in contact with a certain type of illness, you'll have a protocol about that as well. We'll go on in the next video.